good afternoon. I'm Dr. Jonathan Slutzman. I am at the Massachusetts General Hospital and Harvard Medical School. And I am also an environmental engineer, which I practiced for a number of years prior to becoming a physician. I see another engineer here who's kind of recovering too. And we're going to talk today about how healthcare environmental pollution is hurting our patients and that we can actually do something about it. We have tools available and we can do better. So the themes we're going to talk about in a very short time. I can give this talk in 20 minutes or I can give this talk in 4 hours. So we're condensing a lot here. So if there are things that don't immediately make sense or you would like more detail, please feel free to ask. If we can fit it in right now, that's great. Otherwise, I have plenty of time to talk afterwards. So the themes are that healthcare pollution has impacts, that we can measure them holistically, which I think is key, and that both environmental and financial costs matter. I have no particular conflicts to disclose. Let's talk about the problem. Healthcare is energy intensive. Among all commercial buildings in the United States, healthcare is the second most energy intensive facility among all commercial buildings in the United States. Energy intensity, if you don't know, is the amount of energy used by a facility divided by its area, generally in square feet. So this is in thousands of BTU per square foot. The reason I point that out is that number one is food service. But it's not industrial food service because these are only commercial buildings. So it's basically fast food restaurants that use a lot of energy to cook their food and have a very small footprint. Hospitals are number two, which have a huge area, a huge footprint. So just imagine how much energy we're using that we can still be number two in intensity when we divide by the sheer area of our hospitals. That energy and other things contribute to a huge greenhouse gas footprint. Anybody have a guess other than Emily? If we put U.S. healthcare, just the healthcare industry of the United States on this chart, these are 2013 greenhouse gas emissions from the countries in the world, where would U.S. healthcare fit? I will give you a hint. It is not between China and the United States. So it's lower than that. All right, Pierre says Italy. If you can't tell, Italy is, where am I? There it is. Italy is over here. So that's about close to the 20th in the world. Any other guesses? We're going with Japan. Stuart says Japan. Japan is a lot more. Okay. So U.S. healthcare would be the 13th largest country. It's more greenhouse gas emissions than the entire United Kingdom and about the same as South Korea. If you have any appliances made in South Korea, healthcare is similar to that. So we have a big problem. And the pollution that we generate turns into hurting people. Yes, you were.
It's an interesting, can you talk back together? Just as far as efficiency of GDP versus our BTU input, I mean, it seems like healthcare, that's frankly less than I would have thought, just if we're 18-20% of GDP. It's like,
yeah, so it's a fair point. If you normalize the economy solely based on dollars, then healthcare generates a disproportionately low amount of greenhouse gas emissions. But remember that there are industries like building cars and cooking food that would generate much, much more than their GDP would say. U.S. healthcare is about 17-18% of the economy and generates 10% of the greenhouse gases. Yeah. Are you tired of the winning? So our pollution hurts people. These, on the left, you see the different impact categories, global warming, acidification, particulate matter, eutrophication, ozone depletion, smog, ecotoxicity, and then human health cancer and human health non-cancer. And you can take the total amount generated by healthcare and translate it into DALYs. DALYs are disability adjusted life years. It's basically a way to economically measure and compare different health states. So pollution from U.S. healthcare, according to this table, generates at least about 470,000 DALYs per year. But you see that there are a bunch of blanks. So at the time that this paper was done, there was no good model for translating climate change into DALYs or acidification or eutrophication. So then subsequently, there were 5 studies that looked at translating global warming, climate change, into disability-adjusted life years. So how much are we causing morbidity and mortality on people? And the answer is about 209,000. So you add that to the first estimate, subtract some because in the interim there were some shifts in power generation, and you get 679,000 disability-adjusted life years lost because of healthcare pollution every year. This is just from healthcare pollution. In 1999, the Institute of Medicine said that medical errors were responsible for between 45 and 98,000 deaths per year. I'll do the math for you. Deaths and disability-adjusted life years, if you convert those units, these two are the same order of magnitude. They're basically within rounding errors of each other. So healthcare pollution is hurting as many people as medical errors. How many people's hospitals have a chief quality officer or a chief safety officer? Raise your hands. We all work in the same place. All right. How many people have a chief environmental officer or chief sustainability officer? Now you do. Kind of not. You do not, Philbin. We are. So it's the same kind of problem. So what can we do about it? The reality is we talk about energy, but the single largest driver of healthcare pollution and the ill effects of healthcare pollution is clinical care. It's what we are doing for our patients to make them better. It's using high-tech equipment. It's packaging. It's upstream emissions from pharmaceutical plants or from medical equipment manufacturers or from the transportation required for all the shipping to get our stuff. It's from the water use in our autoclaves. It's from all of these things, but it all comes down to clinical care. Now, wouldn't it be nice if there was some way that we could measure the environmental impacts of the things we do? Good news, there is. Life cycle assessment is the tool that I think is the best for this purpose. It's a holistic method to look at a product or a process from cradle to grave. Raw material acquisition, transportation, refining, manufacturing, more transportation, use, reprocessing, reuse, disposal. And what are the energy inputs and environmental outputs along each step in the life cycle? What I really like about life cycle assessment is it is the emergency physician's way of looking at the problem. We are among the few remaining physicians who still look at the whole patient. I'm not just looking at what are the emissions from driving the car to go and take the patient from their home to the office. I'm also interested in what are the emissions associated with making that car and disposing of that car and all the other things that go into it so that we can really make an apples-to-apples comparison. There are 4 steps to a life cycle assessment. Again, this is a very condensed version of how to do it, but there are 4 steps. Goal and scope definition, so defining what is going to be in my study versus out. In most cases, life cycle assessment is done comparatively to compare 2 products or processes that you might want to decide between. It can be done not comparatively, but most of them are going to be comparative. So how can we define our system so that we capture all of the relevant differences? An inventory analysis, where you would say, what are the parts in our system? We then translate the inventory into an impact assessment, and then all along you're trying to interpret and analyze the data. Any questions so far? This big 40,000-foot view here. So let's go through an example. This is a published study from 2018, anesthesia and analgesia. I chose this one partially because I think it was well done, and partially because it is directly relevant to emergency physicians, and partially because there has never been a life cycle assessment published in the emergency department that I could choose as a different example. So laryngoscopes. How many people use reusable laryngoscope handles with reusable laryngoscope blades? Okay. How many use reusable handles with disposable blades? A couple. How many now use disposable handles with disposable blades? How many people don't know what a laryngoscope is? Because I think I covered all the possibilities. All right. So there's quite a movement to go to single-use disposable equipment in most of the things we use, and we'll cover a little bit about that. So here the question is reusable versus disposable laryngoscopes. This is the scope definition of this study. You'll see the single-use disposable on the top is basically you got to get the raw materials, you got to make it, and then you got to package it and transport it and use it and then trash it. The reusable one is a little bit more complicated because you got to throw in here that you need to clean them, which means I also need to know about the stuff that's used to clean it. I also need to heat the water to sterilize it or wash it, and I need to reuse it, so there's a cycle here, and then eventually I'm going to have to get rid of it when it's no longer usable. It also means that I need to know how many times I can use it before it's no longer usable. And then this study takes it one step farther and says, okay, well, environmental impacts aren't the only concern when we're choosing. We also need to be financially sustainable in addition to environmentally sustainable. So let's look at the costs. And let's look at those from a full life cycle as well, since the important part is not just acquisition of the parts, it's also the labor involved in low-level disinfection, high-level disinfection, sterilization, refurbishment. It's the waste disposal fees. It's the cleaning and energy needs. So let's be holistic, apples to apples. So this is how they did their study. If it's important to you, it was done at Yale New Haven Medical Center, so some of the numbers are specific to that facility. The inventory is to some degree the most fun part. It's when you get to take your equipment and take it all apart, figure out what it's made of. So here you have a laryngoscope blade. Here's a multi-use steel laryngoscope blade. It has 70 grams of steel. It's got some fiber optic glass, some paper. And then if you look at the single-use plastic, it's got polycarbonate mostly, but then some fiber optic glass and paper. And then the handles, similar mixture of stuff. What's perhaps most interesting, and it's going to come out later, is that the single-use handles have a battery in them, which we are going to use once and throw away. So we can translate that inventory into impact assessments. A lot of times this requires commercially available data, since it's really hard to get the individual manufacturers to give you the marginal data. So there are publicly available data sets that cover just about any manufacturing thing you could think of, with the exception of pharmaceuticals. So you can translate it into, if I need to make this much chromium steel, it's going to have X amount of benzene emitted and carbon dioxide emitted, and it takes this much energy. And there are software packages that you can use to automate much of this, to make it much, much easier. You then, in the end, add up all those and translate them into categories. In most cases, we use around 9 to 12 different categories, similar to the ones that you saw in that first chart. Ozone depletion, global warming, smog, acidification, and so on. Because in most cases, nothing is ever best in all of them. So you have to make some sort of value judgments on what is most important to you in your particular situation. So here are the data for the laryngoscope blades. The multi-use high-level disinfection was the best in all of them. I mentioned that's a rarity. It was in this case. And then the others are all scaled. So, for example, a steel single-use disposable blade emits 158 times the impact of carcinogenics compared to a reusable steel blade. You can then plot it so that it actually looks better. This is the table as presented in the actual paper. I then translate it into charts because I like to see the chart better. I also reverse the scaling because otherwise the chart doesn't make sense. So here we have the laryngoscope handles, and what you'll see is that the multi-use low-level disinfection on the handles is better in every category except for ozone depletion, ecotoxicity, respiratory effects, but it's pretty low. The multi-use high-level disinfection is even lower. Difference between low-level disinfection, high-level disinfection. It turns out those wipes that we use, the Super Sani wipes or whatever one you happen to use in your hospital, there's a lot of stuff that goes into making those, and you can't use them on very many pieces at a time. So that's where this impact becomes so high. But what you really see is that that single-use disposable steel laryngoscope handle is terrible. It's the worst in almost every category. The blades aren't really any different. And you can quibble about the exact numbers a little bit, but when the pattern is so stark, the impact is huge. What you can then do is dive a little bit more deeply. So what I showed you before is just the whole device in each category. You can then say, okay, well, what are the important stages, the important pieces of the life cycle that contribute most? And so this is just looking at greenhouse gases in the handles and the blades. And what you'll see is that the single-use handles and blades, the vast majority of the greenhouse gas emissions come from the production part. Basically manufacturing it, packaging it, and sending it to you. And the rest is pretty small. Whereas in the reusables, you see much more of the impact comes in the reprocessing and repackaging. Kind of makes sense. You only have to make it once. It lasts a lot of times, but each of those times you have to reprocess it. So that's the power of the tool. We can then add to that the cost, and I'll make it easy for you. The reusable ones are cheaper in all cases in this study. What do you think they actually use at Yale New Haven Hospital now that they've done this whole study? They still use single-use disposable laryngoscope blades and handles. So what else can we compare? This is about one example. And I already told you that there haven't been any done in the emergency department yet. We're working to change that. Here are scissors, anesthetic drugs. And I can talk a bit about that if you're interested. Single-use central venous catheter versus reusable kits. Plastic anesthetic drug trays. These are drapes, reusable or disposable OR drapes, done in Germany, so it's in German. Reusable and disposable LMAs, OR custom packs, a hysterectomy. So this study was open versus laparoscopic versus vaginal versus robotic hysterectomies. And what are the environmental impacts of those? That was another case where one of those four turned out to be the worst in every category. So we can compare lots of different things. What are you going to do? What kinds of things do you want to look at? And how can we work together to bring this into the emergency department and really show that what we do has an impact on our patients and is causing them harm from our environmental footprint? Any questions? Liz?
So in all those studies that you just showed, is there kind of an overall trend? Like, do multi-uses overall save everything? Because if there's enough of a trend, then you could do X number of studies and kind of say this is the way it is, or are they all over that?
Yeah, good question. Every single published study on reusable versus disposables, save one, has shown that reusables are environmentally superior. Save one. Yeah, please.
So why do hospitals continue for the single-use disposable?
Oh.
Is there a difference as far as infection rates or like other?
Yeah, so, okay. All right. Is there a difference in the infection rates? The answer is we don't know. But what we do know is that the difference, if there is one, it is minuscule. There is a great fear among hospitals with respect to accrediting bodies, for example, the Joint Commission, but they are not the only one, that if you can't describe your process for ensuring that you have completely, perfectly disinfected whatever device, then you're not in compliance because it is an infection risk. Until fairly recently, within the last couple of years, laryngoscope handles were classified differently than laryngoscope blades because they didn't actually touch patients. Forget about that they didn't go inside the patient. They didn't even touch the patient. So they could be low-level disinfected with the wipes. I think it was CDC who then reclassified them and said that they are now the same level as a laryngoscope blade. There are no data to support that reclassification, but it resulted in the single-use disposable manufacturers getting very, very happy. And they are very happy to sell you single-use disposables for a very small amount of money. This is a plot. The folks who wrote that life cycle assessment on laryngoscopes in the same issue wrote a commentary on the infection risk. This comes from that. And it shows over time from 1800 to 2000 the survival after a major leg amputation for trauma against the infection rate in clean wounds for major operations. And what you see is that there's very little room to improve this. Like that red line, it can't really get much lower. So anything that we're doing for infection control is really nibbling at the edges. Without hard data, I would say that almost certainly the human health risks from the single-use disposables on an environmental perspective are greater than the health benefits from potentially avoiding infections. And it goes along with this chart that really, as we move to the right here, the risk of infection might go down asymptotically, but at the same time, the risk of indirect disease, basically the environmental impacts, goes up. All right. I need to give over the room to the next speaker, but if anybody would like to find me and talk more, I'd be happy to.
You can keep talking. I just want to get set up.
Okay, go ahead. Yeah, Emily.
In terms of the institutions that did the switch, that switched over from disposable to reusable, how long did that turnover?
To go from reusables to disposables or disposables to I'm not aware of anybody who's done it yet. Yeah. So if you just look at the product acquisition costs, it's multiple times more expensive to buy a reusable piece of equipment. But if you look at the life cycle cost, most of those life cycle assessment studies have not done costing, but the ones that have generally shown that the life cycle cost of the reusable is lower.
One key thing is, we'll find out in a second if this is going to work.
Yeah, so the studies that use, and it's going to vary based on the piece of equipment. But they all turn positive on a reasonable life cycle. Yeah. Joint Commission. Yeah.
Am I allowed just to switch over to my computer? I have a feeling with the tight time frame now, I don't know if I'm going to be able to figure this out.
What are you trying to do?
It's audience response. It's built into the session.
So
it's not letting me just do it.
Yeah. I don't have great advice because I can't say that I've been amazingly successful yet. But what I can say is that in order to do it, you need to get the right people involved. There are hospitals that have had good success, particularly in things like anesthetic gases. We didn't talk specifically about that, but of the all 4 generally used anesthetic gases, desflurane, sevoflurane, isoflurane, and nitrous oxide, are all greenhouse gases to varying degrees. Desflurane is much orders of magnitude worse than the others, and a reasonable number of hospitals have gotten desflurane taken off of their formulary. For that reason, it also helps that desflurane is very expensive. So it involves getting the right people involved. So in this case, it's infection control, it's your anesthesia colleagues, it's your infectious disease colleagues, it's your environmental services or central supply or materials management, whoever that is, to really show that it can be done feasibly. You're very welcome. Thank you. Yeah.
Keep me the books that are fun to work as well because it helps.
Yeah, nobody's really working on it yet. There are a couple of organizations that I think are well suited. So Practice Green Health and Healthcare Without Harm, I think, are the best ones to really move this at that large level. An individual hospital is not going to get the Joint Commission to do anything.